Invitation to be here. It's a real pleasure. I'm going to be talking about current cost effectiveness thresholds that are used in low and middle income countries and how appropriate these are for use, and I'm going to give some examples from the world of vaccines. It came to my attention yesterday that the title of this presentation is actually the title of a paper that Raymond is a co-author on. So sorry for that. It is got a slightly different focus than that paper, but that is actually quite a good paper as well, so would recommend reading that too. Okay, so I'm going to talk through why we need thresholds. And I put thresholds in quotes here because there are a lot of different numbers out there, different values that are referred to as thresholds. They have different conceptual foundations, and they need to be sort of seen differently. We need to determine what a threshold really ought to be called and what is appropriately should be defined as a threshold. So then I'll talk about what thresholds are appropriate, going through demand-side estimates and supply-side estimates separately. And finally, I'll give 2 examples, and I'll finish with discussion and conclusion. Okay, so why do we need thresholds? Well, all healthcare systems face difficult decisions regarding how to allocate scarce resources to generate improvements in population health. And these difficulties are compounded in low and middle income countries where these constraints tend to be bigger. So we may have smaller budgets, fewer human resources for health, less infrastructure, bottlenecks, supply chain issues. All of these are problems that we face that are more difficult to overcome in low and middle income countries than in high income countries. Further, there's an opportunity cost to everything that is done, whether it's done by governments in terms of making decisions around how to spend collectively funded, collectively pooled resources for healthcare, or if it's a decision made by donors in terms of how they're spending their funding, whether it's contributing to a sector-wide approach for health, or if it's a vertical program, or contributions in terms of funding new research or the development of new vaccines and drugs. There's an opportunity cost to our time here. We could all be somewhere else doing something else, and that those other things that we could be doing are the opportunity cost of us being here. So essentially there's no such thing as a free lunch. So whether a health intervention, be it a vaccine, a technology, a drug, or a device, should be funded depends on the total health that it generates and how much it costs. And this is typically summarized as a cost-effectiveness ratio. So that's just the difference in terms of cost between what we are interested in funding versus its comparator, and the difference in effect in terms of what we're interested in funding and its comparator. And this requires a comparison with some benchmark value or a threshold. So if it's cost-effective, it'll fall below that threshold value, we should fund it. If it's not cost-effective, it falls above the threshold value, we should not fund it. But there's little clarity and much confusion in terms of what thresholds are appropriate, and this is evident in the values that are recommended and cited by decision-making and advisory bodies. And what this comes down to really is just a failure to distinguish clearly between what I'll call the demand side and the supply side. So the demand side tells us really what the value of health and healthcare expenditure ought to be, whereas the supply side gives us an indication of what improvement in health is possible given our existing resources. So that takes into account these constraints, particularly the budget constraint. So demand side estimates are those which seek to inform the social value of health. In other words, what should society pay for improvements in health? And these are generally based on evidence of how much consumption individuals are willing to give up to improve their health. And these have been recommended by some agencies. I think it's the Commission on Macroeconomics and Health by the WHO in 2001 first recommended thresholds based on GDP per capita. And these were meant to be indicative to tell us sort of what things could be termed to be highly cost-effective or cost-effective. So if something was less than 1 times GDP per capita, it would be potentially highly cost-effective. If it was less than 3 times GDP per capita, it would be potentially cost-effective. And if it was above that, it would not be termed cost-effective. So these have been used as generic and internationally applicable criteria to classify interventions. They're very widely used in the literature. so I'm sure you're familiar with. But they're also very widely recognized as having shortcomings. So they tend to, if we use these estimates, we risk reducing overall population health and exacerbating inequalities. We also will fail to identify the real and possibly much greater value of devoting more resources to healthcare. These values tend to be they are conceptually different from supply-side values, and they also tend to be numerically different, and as such, they will result in different decisions being made. So demand-side estimates are generally higher than supply-side estimates of the marginal productivity of spending on health. And so if we were to approve an intervention on the basis of a demand-side estimate, and it turns out that we wouldn't have approved it on the basis of a supply-side estimate, we will actually reduce overall population health. So supply-side estimates, on the other hand, represent the health opportunity cost of marginal changes in expenditure, where these changes are funded either through additional resources, so that's the health effects of things that are likely to be done if the resources were made available for other healthcare uses, or through disinvestment in existing commitments, and that is the health effects of things that are likely to be given up. And these estimates can be obtained from estimates of the health effects of changes in health expenditure, as was done in the United Kingdom. There are also estimates available for low and middle income countries from work done by Woods et al. And work that I've done with colleagues. So I've kind of alluded to this, but it's worth reiterating. So these supply-side estimates are useful for government decision makers who are working with constrained budgets, who are interested in whether funding a new intervention, whether it's a new vaccine or any sort of treatment, with a given budget will result in an improvement in health outcomes overall, or if that money would be better spent elsewhere. It's also useful for donors who are contributing to the overall funding of a healthcare system, or towards specific interventions or programs, and particularly donors looking to fund the development of new health interventions. So if we can indicate something about how effective a new vaccine or intervention is likely to be and what we think the cost of that might be, that gives us an idea of whether or not it's likely to be cost effective at the country level, if countries should adopt it or not. And if not, that indicates that that money for investment in the new vaccine or technology may be better spent elsewhere. These are also useful for prioritizing between a set of cost-effective interventions. So if we have interventions for which we have the same cost-effectiveness ratio, we can't, on that basis, determine which one to prioritize. But with additional information about the marginal productivity of spending on health and also the size of the population that stands to benefit from each intervention, we can use that to prioritize between interventions. And finally, this can give us a maximum that we should be willing to spend to implement or to develop an intervention. And I'll go through these last two in a bit more detail with the examples. So first I'm going to give sort of a hypothetical example based on Malawi, and then I'll give an actual example based on Malawi. So for Malawi, we have a supply-side estimate of the productivity of health spending at the margin, and this comes from the range of estimates that was produced from the Woods et al. Paper and the paper that I co-authored. And our estimate, the mean of the range that we have is $61 per Dali averted in 2016 US dollars. For the demand-side estimate, if we take 1 times GDP per capita in Malawi, that gives us $381 per Dali averted. So that would tell us anything that based on GDP per capita we would expect to be potentially highly cost effective. So if we have a hypothetical intervention, A, with an incremental cost effectiveness ratio of $150 per Dali averted, we can see that using the demand side estimate, we would approve this. It would be seen to be cost effective. However, using our supply side estimate, we would not approve it. It wouldn't be cost effective. However, this doesn't really tell us anything about the overall health gains or potential health losses that might be incurred if Malawi did decide to approve this intervention. So for that, we need a metric of health benefit. So for that, we can consider net DALYs averted, which is sort of the same thing as net health benefit, or you can think of net qualities gained. And mathematically, that's equal to DALYs minus the cost divided by our estimate of the marginal productivity of spending on health. More intuitively, that is the health gained by the intervention over and above the health losses that are incurred by the costs imposed by that intervention. So given our hypothetical intervention A, We can see the first line of the table here, just looking at a single patient with a cost of $1,500. We avert 10 DALYs, and what we end up with is a net DALYs averted of -15, using our estimate of the marginal productivity of spending on health. But this only tells us something at the patient level. What we really want to know is how does this play out at the population level? So if we were to scale this up by, say, 10,000 patients, we can see the cost goes up by that amount as well, and DALYs averted now are also for 10,000 patients. And what we have is an effect of -145,902 DALYs that are now imposed on the system by approving this intervention. So looking at a real-world example, we can look at a paper by Berry et al. In 2010. So sorry, I keep talking about Malawi, but that's where most of my work is, so it's just easiest to pull examples from. But there's a paper here called The Cost-Effectiveness of Rotavirus Vaccination in Malawi. So this looked at a time horizon of 2 years, because most children are infected at least once by their second birthday, and most of the health effects and the ill effects of infection are felt the first time an individual is infected, as they build up immunity after that. The DALYs were calculated using mortality data and mean duration of diarrhea being 5 days. And the costs include program costs, which were cold chain, transportation, personnel time, and stationery, as well as outpatient visit costs, and they incorporated a wastage rate of 10%. They used a 3% discount rate for health effects and costs. And even though the vaccine sort of saves downstream costs, it still imposes a net cost overall because of the cost of the vaccine itself. So I haven't included in this the actual costs, but there's like a final slide on that, which I can go over if anyone's interested, and it's also included in your pack. But I've just looked, so I've calculated the cost-effectiveness ratio, and then also net DALYs averted using our estimate of the marginal productivity of spending on health. So we can see here the Rotarix vaccination versus no vaccine at Gavi prices has an ICER of $5 per DALY averted. However, at market prices, it's $75 per DALY averted, so not cost effective at that. And now incorporating the size of the birth cohort that would be vaccinated, which was given in the paper as 582,211, we can calculate net DALYs averted. And so we can see at the Gavi price, we avert 72,500 DALYs. And at the market price, we incur a loss of 17,800 DALYs. We can also calculate the dollar value to the healthcare system, which is just how much it would cost the healthcare system to avert, let's say in this case, 72,502 DALYs at the margin. So that what this tells us is useful for two things. For one, if this vaccine didn't exist, let's say, and we were interested in developing it, but we knew how effective it was likely to be and how much it was likely to cost from Gavi and at market prices, this could tell us how much we should be willing to spend to develop this vaccine, which in this case would be $4.4 million. If it costs more than that, it's no longer necessarily going to be cost effective. In addition, what this can tell us is how much we should be willing to spend to implement this. So if we can imagine a scenario where there is no infrastructure to implement this vaccine at all, we have to do it entirely separate to the current vaccine infrastructure. If we were to spend more than $4.5 million to implement it, again, it would no longer be cost effective. And so we can also calculate this at the market price. We can see, obviously, since it's already not cost effective, it has a negative dollar value to the healthcare system. Okay, so in this example, we would approve Rotarix under the Gavi pricing structure. We can also use SupplySide estimates to rank Rotarix among other candidate vaccines and interventions in terms of net DALYs averted, in order to prioritize vaccines and interventions that generate the largest gains in overall population health. And this is really important, I think, in low and middle income countries. So particularly, for example, in Malawi, where I've been working recently, the government is interested in developing a new essential healthcare package or health benefits package. And they're not just interested in which vaccines to include in that package, but which interventions overall. So it's important to know the size of the patient population that stands to benefit from each of the different interventions and to be able to rank these because we have a number of infrastructure constraints that we have to deal with in addition to the budget constraint. And so when things are actually implemented on the ground, we may not be able to fully scale them up. So being able to see where to prioritize that scale up is very useful. In addition, we can use this to determine the maximum that we should spend on these implementation costs over and above the cost of each intervention itself, or in this example, Rotarix. And as well, how much we should be willing to spend to develop different vaccines or interventions. So to conclude, an estimate of health opportunity costs is crucial. Demand-side estimates can't tell us about the opportunity cost imposed by an intervention. And there are often substantial differences between supply and demand-side estimates, so which one we use in decision-making is really important. Thank you.